Well, good afternoon again, ladies and gentlemen. For those of you who are staying the course, this is my last of my 4 talks today, and I'm wheeling it back to the UK tomorrow morning. So I'd just like to thank again the organising committee for inviting me. I've had a great time. I'm really enjoying it. So, have we left the best to last? Well, we'll see by the end of it. Let's go back in time to a year. I'd been in ophthalmology for 3 years when this paper was produced in 1982. Why do some people go blind from glaucoma? It's a seminal paper which is not now shown very much, but we can still learn a lot from it. Morton and Grant's paper. They took the patients over many, many years who'd presented with high-pressure glaucoma. This group had had normal fields, some disc cupping they called it, we'd call it excavation, and they showed that over many years follow-up, that blindness was associated with higher IOPs. The open circles at the bottom are the people who didn't go blind, and the closed circles at the top are the people who did. Now, these people started with normal fields. If you took a group of people who had loss in one hemifield, then blindness occurred at lower pressures than when there was no field loss at presentation. But you can see again, although the patients who survived, the ones with the open circles, were very high to begin with, they got lower pressures than the group who didn't. And similarly, if you had loss in both hemifields, then blindness occurs at lower pressures still. And the only people who kept their sight were the people with really low pressures. There's a very good message there. And after nearly 40 years of dealing with glaucoma, I agree with that message. So let's look at this in another way. What are the risk factors for progression? Well, at older age, interestingly, higher pressure, worse field, pseudoexfoliation, and both eyes having the same problem. In the AEGIS study, some of those factors are similar. Higher IOP over follow-up, frequent disc hemorrhages, exfoliation, and of course race here as well. And this is the classical slide from the AEGIS study, which shows you that if you average a good low pressure and you never have a pressure over 18 in this study, which was not advanced glaucoma, by the way, it was just glaucoma, you had a good chance of not progressing, whereas if you didn't, you did. So why don't we perform glaucoma surgery on more patients? Well, we worry about the risk of immediate visual loss and we're talking about trabeculectomy for the purposes of this argument. Infection. It's actually really rare after trabeculectomy. I've only had one case in my whole career, and that was a person who went off and had acupuncture in his eye 4 days after his operation. Not a good idea. Hemorrhage. Well, that used to be more common, but it's a much more controlled operation nowadays, and that is very rare to have intraocular hemorrhage or early post-operative hemorrhage. This worry about snuff out. Again, in my experience, it's extremely rare with careful case selection and good post-op care, making sure the pressure doesn't go high afterwards. I'll talk more about that as we come along. Hypotony, that was a bigger problem, particularly with the use of mitomycin C, but it's rarer with the use of careful controlling of your trabeculectomy flap afterwards. I introduced the idea of laser suture stretch, which instead of lasering the suture and cutting it, you use sub-threshold laser energy to stretch the stitch. It works brilliantly. Please look at the paper. It's fantastic. You just don't get hypotony if you use stretch rather than laser suture lysis. Or you could use adjustable sutures, but you can only really take them out or leave them in. Not as good as suture stretch in my view. What about delayed visual loss? Well, again, you're worried about this long-term blebitis and endophthalmitis, and there was a sort of epidemic of this in the 1990s, early 2000s. But with the modern use of mitomycin, spreading it out in the safe surgery system that was expounded by Pen Kaur and his team from Moorfields, the risk is much less than 1% risk in the 5 years following your operation. What about complications of cataract surgery in an eye you've done glaucoma surgery on? Well, with modern glaucoma surgery and an experienced cataract surgeon, it's not a big problem. Yes, you will get an increased number of cataracts to do, if you don't do the cataract first, that is, and that can sometimes be a good idea. But even so, with modern surgery, with good instruments by experienced surgeons, it's not a problem. But what about delayed hypotony? Is that a real problem? Well, let's look at some of the evidence to this. This is an American study published 2 years ago. where they looked at what caused visual loss following trabeculectomy. And hypotony is obviously a question. It's a big study, a lot of data there from over many years. And if you look at the Kaplan-Meier survival plot, these are people who have lost their vision, either with hypotony or without. They parallel each other. And in fact, if you don't have hypotony, the commonest cause is worsening of your glaucoma. So that's probably too late an operation. So let me use a case illustration for this. We have this lady who I first saw when she was 62 in 2002. She had open-angle glaucoma diagnosed 7 years beforehand. She had full fields at that point. Family history of blindness from glaucoma, really important. She does have sleep apnea, but it's because she has an abnormal lower jaw rather than a vascular problem. She's hypothyroid, she has inactive Crohn's disease. She had rapid field progression in her left eye and a defect in her right eye. Her pressures were just under 20 on 2 drugs. Acuity was normal with wide open angles. Normal color vision and MRI scans have excluded other causes. Look at her field. This is her left eye field at presentation 7 years after a normal field. And the bottom one is her 10-degree field. Still good acuity here. In her right eye, there's her fields at presentation to me. Remember, normal, 6, 7 years beforehand. 10-2, quite bad. That's a bit faded, that picture, I'm afraid. Sorry about that. But quite bad glaucoma in terms of being close to fixation, isn't it? Well, I operated on her in March 2002 and kept her pressures down at 6 to 8 millimeters of mercury. And there's the difference in 15 years. And her field is actually slightly better 15 years later. I think I've stopped that patient from going blind in that eye. And there's the 10-2 field. Well, it looks slightly worse because it's a darker printout below, but actually the mean defect's very similar. Really hasn't changed at all. Here's her other eye showing progression in just 1 year from 2000 to 2001. It's got mean defect of 4 decibels worse. And there is the difference in the 16 years after, or 15 years after surgery. Yes, it's got a bit worse. I haven't stopped it dead, but it's only lost 2 decibels in 15 years instead of 8 decibels in 7 years. But the other side of the coin is this lady who was referred in 2011 to me, normal tension glaucoma diagnosed sometime before that with a real bad defect in one eye and a defect in the other eye as well. Highest pressure only 21. She's a myope. The right eye lost acuity from glaucoma in 2007, 4 years before I saw her. So here's her left eye, still 6'9", but progressive field loss, but pressures between 10 and 14. Pseudophakic, but a myope beforehand, no negative MRI, nothing else wrong with this lady, just myopic. Her pressures were 10, with slightly thinner cornea than our population average, but a low hysteresis. For those of you who don't know, that's pretty low. So she got a weak cornea from her myopia. Those are her fields at presentation to me. 10-degree on the bottom, 24-degree on the top. Operation, couldn't do anything else. Clearly was getting worse. Did quite well, pressure 6. Acuity great for, most of the first year. Looks like a success, doesn't it? But this is not a good story because over a period of time, despite having excellent pressures, her vision gradually disappeared. Her central vision over the course of the next 2 years, and even worse by January 2017. She'd gone blind from glaucoma, despite a very low pressure. So why is that? Well, the clue is in the 10-2 field. I'm going to blow up the 4 central points. If you think about the 24-2 field, the points are 4 degrees out from the middle, the nearest point. It's useless if you're looking at advanced glaucoma. You must do 10-degree fields, absolutely vital. Here's a 10-degree point. These points are really close to the middle, and she had almost got snuff out on 2 of those points, and they're in different hemifields. If you have 2 in the same hemifield and your bottom hemifield's okay, you may be all right. But in my experience, if you've got poor points in 2 hemifields, you're doomed. You're on the slippery slope. And even if you lower the pressure surgically, you're still going to go blind. And I've seen it lots of times. So when do I operate in open-angle glaucoma? In very high OPs, despite medication and laser, the pressure's far too high. When you've got evidence of significant field progression that threatens vision during the lifetime of that patient, when one eye is blind from glaucoma and the other eye has significant field loss, don't mess about. We're good at doing surgery now. If you can't do it, send it to somebody who can and who's used to doing it, unless the patient has that sort of degree of 10-2 field, where you might get snuff out. I was lucky I didn't. I probably didn't preserve the patient's vision for much longer than they might have done, but we don't have evidence for this yet. Thank you very much.